Great introduction. To your point about the importance of an employee insurance package, I just heard a statistic about one of my favorite companies, Starbucks, last week. Before they started offering health insurance benefits to their employees, the average tenure of their employee was 8 months. Once they introduced a health insurance option, it converted over to a 2-year average tenure for their employees. So that just kind of speaks, and I know that all of you are HR experts in this room, to the importance of that insurance package and that total overall benefit package. But it's a delicate balancing act in what you offer and what you pay. So today, I'm just going to walk through kind of the nuts and bolts and the basics of self-funding, kind of self-funding 101, the components that, reasons and advantages to self-fund. Larry really teed me up great in giving you all of the regulations that have gone into effect, which really kind of lead into why this is becoming more prevalent and more of a conversation that's taking place within the health insurance industry. We'll talk about the key components to a self-funding solution. What does self-funding mean, and what makes up that? Are you on the hook 100% for all of your employees' claims? Are you actually, as employer, writing checks to the doctors and hospitals? No. So we'll kind of talk through the logistics of that. The importance, and one of the reasons I'm here, is the provider network and what that brings to the equation, and the importance of the cost control that the network brings to the overall cost containment and what is paid out. And then what size groups are eligible for self-funding? Obviously we walked through the small group market earlier, and you obviously, Bill mentioned that it's becoming more of a viable option for the small group market, where it's traditionally just been the 100 employee and over market that's looked at self-funding. We'll touch upon some self-funding glossary and terms. It sounds like there's some in your folder as well. And then wrap up with keys to comparing self-funding to fully insured. So please feel free to raise your hand as I'm speaking. I want to make it interactive, answer your questions as we go along. You don't have to hold them till the end. And again, there's a lot of experts here in the room too that can help assist. So how many of you, or of the HR folks that are here, are in a self-funded solution right now currently with your health insurance? Okay, great, we've got a mix. Can anyone take a guess at how many employers, the percentage of employers in the United States that are currently self-funded or self-insured? Oh, I saw a finger. 60%. Oh, very close, 57%, which was kind of a surprising stat when I read it. Obviously, the majority of them are your really large corporations that kind of make up that. But there really, there is an increasing trend over the past 2 to 3 years in a shift over to that self-funded market. And some of the reasons why is, number one, is that it is regulated, self-funded plans are regulated by the federal government. So they're not regulated at the state level. So many of the state mandates that vary from state to state, and we live in Illinois, we're a very generous state, are not mandated in a self-funded plan design. An example of that may be infertility. Here in Illinois, you can have so many retrievals and unlimited in vitro procedures, which then oftentimes, are expensive in itself from a medical spend perspective, but there are a lot of downstream costs to that as well in an infertility situation. They often result in multiple births that are high risk, and you hear about those $1 million babies. So that's just some of the customization that is allowed in a self-funded arrangement, and avoiding some of those state mandates. You also have greater flexibility in your plan design. We walk through some of the what ACA mandates as far as a plan design. There's state mandates as far as plan design. In a self-funded arrangement, you can really become creative and customize a solution for your specific employee population. An example that we've been working and implementing into the market is you can take you traditionally have an in and out of network benefit for your plan design. Take that and make that a 3-tier option, tier 1, tier 2, and then out of network, and shift your more cost-effective providers and hospitals and doctors into tier 1, your less cost-effective providers in tier 2, and then out of network in 3, and then you can customize the benefit for each tier to incent your employees to use those more cost-effective providers. That's very important when it's your dollars that are being spent as the employer in a self-funded solution. So just an example of how you can get creative and be flexible with that plan design. Also, there's a greater importance and delivery of transparency in the self-funded solution. It's your dollar as the employer that's being spent. Thus, you are have access to a wide variety of data and reporting from your third-party administrator, from your network, from disease management, wellness. You can see what your employees are taking advantage of. You can see where the claims dollars are being spent, what parts of the benefits are being overutilized, what's being underutilized, so that you can make real-time decisions as far as your benefit design. So that all that information is available to you. For those that are fully insured, you're probably aware, typically, I think it's like 150 employees or more for the most part now in the industry for you to receive any type of like claims reporting in aggregate to see how your group is running or where the claims dollars are going and the utilization of your employee population. Typically in the small group market, you see your renewal once a year and you see the percentage of what you're going to pay more, and that's about it as far as information goes that you receive. And then we really, Larry did a great job of kind of explaining the detail between all the taxes and fees that came along with the Affordable Care Act. I think I heard that there were over 63 taxes and fees that the Affordable Care Act brought us. Question, pops in your mind, the word affordable being part of that name. But there are three big ones that, affect the insurance industry, and self-insured employee arrangements are exempt from that health insurance industry fee that Larry mentioned, which is approximately 2.3% of your annual premium. So if you were fully insured, that would be a tax that you would be liable for. And there's just a recap of those taxes. And then community rating, or the Fair Health Insurance Premium Rating Act that is in effect now. Upwards of 20 to 50% I've heard in the industry as far as a cost increase when a small group moves into a community rating pool. That obviously, is a dramatic, line item increase to your budget as an employer once you move into that community rating world. We've kind of, the blow has been lessened because of that transitional relief, but, we're not sure if that's going to continue. But when it does end, the majority of small groups are going to be subject to, providing essential health benefits within their plan design, and no longer using the status of health as part of that determination or that mathematical determination of their premium. So, moving into that community rating really is going to have a substantial price increase to a fully insured small group. With a self-funded arrangement or solution, health still can be used as a determining factor in premium. So that is not, the self-funded solution is not subject to that community rating or the Fair Health Insurance Premium enactment of the Affordable Care Act. So that's a definite differentiator between the two different funding mechanisms. One example is that an essential health benefit is pediatric dental and vision. You may be a 55-year-old with no children, but you're going to pay for pediatric vision as part of your plan because it's mandated to be included. So really, self-funding is a great option to look at if you're an employer that has, right now a healthy population, as far as you're aware, that wants to really succeed at rewarding the employees by lowering their costs, lowering your out-of-pocket costs, and is willing to fill out individual medical applications to be used in the underwriting process. The more information an underwriter has, the more comfortable and the more specific the rate is going to be to your specific population. Taking a look, at fully insured versus self-funded, fully insured is kind of a one-stop shop. There's a lot of, there's actually, the market's really lessened. There's some really large fully insured carriers in our market. We kind of refer to them as the BUCAs. It's your Blue Cross, your United, your Cigna, your Aetna's, Health Alliance. And when you go to a fully insured carrier, you're going to receive your package of your medical benefits, your network, your pharmacy benefit manager, your disease management. It's all going to be in one package for you. So very little room for customization. You might be able to adjust a deductible within a certain range, adjust a copay for a pharmacy or a prescription. But for the most part, here's what you get, and you pay one set price for it. So whether or not your medical claims are, in a very good level or whether they exceed it, you're going to pay that flat amount, and that's going to cover your claims, whether or not it meets your claims or it doesn't. In a self-funded arrangement, you're going to pay premiums based on your actual claims experience. not the experience of your carrier's pool of dissimilar companies. So it's very specific to your employer group. And again, as I mentioned, you have the complete control and flexibility of your plan design. Any questions? So the 3 parts of self-funding. The 3 parts include your third-party administrator. And so as we mentioned, we've got Group Plan Solutions, or Pekin, with us. That is a third-party, a very high-quality third-party administrator. You have your reinsurance. And then you also have your provider network, which is going to contain, the cost control of your medical spend. So your third-party administrator, their role is, essentially, and I asked Terry and Bob to definitely, chime in on this. They replace that typical your fully insured carrier, your Blue Cross or your United or your Aetna, and they take on all of those administrative services. They process all the claims for your employees. They become your customer service. They offer disease management programs. They do all of your plan documents, your member materials, your ID card distribution. Is there anything else you want to add to the wide variety of services you offer? Reporting. Yeah, they shop the reinsurance market for you. They work very closely with your consultant or your broker in helping manage your plan. I like the analogy of it really takes a village when he was talking about the reporting that's required. In fully insured or self-funded, it's very important to have a very trusted consultant or broker that to work with, but even more so to find a high-quality consultant when you're looking at a self-funded arrangement, because there's a little bit more complexity. There's a little bit more risk, but there's going to be more reward in the end as well. So, and we'll touch upon reinsurance and the components of that too. That's probably the more complex side of it when it comes to a self-funded solution. And then they definitely help manage your claims. They have a vested interest in retaining you as a client. How are they going to do that? By managing your claims and controlling your costs and hopefully lowering your costs. So they have a lot of innovative predictive modeling tools and out-of-network negotiation that they do to help manage all of that. That captured all. And then you have your network. As Bill mentioned, I work for HealthLink. We are owned by Anthem. We got a lot of great press over the past month. They say no bad press, or no press is not good, but that one was probably not one that we were looking for. And we are a regional network of doctors and hospitals in Illinois and Missouri. And our role is to, as I said, work with the TPAs and the brokers to tailor a health plan and a network that meets the needs of your employees while controlling costs, offering broad access or narrow access to customize the solution to meet the needs of your employer group. We also, as I mentioned, kind of are getting into the arena of how you can really educate and provide transparency in the market to the employee about the cost of their care. Health insurance is one of the few industries that you can go in and receive a service and not know how much it costs until after the fact. So we have been working very diligently with our network of doctors and hospitals and collecting the information and building transparency tools to make available to employees. So there'll be we have a member-facing tool where you actually can go in and put a procedure in and see what the cost of that procedure would be within your network of doctors and hospitals. So it's customized down to the member level and their network. A good example is a colonoscopy, and I know I put that in for the area that I live in, which is in the Decatur-Champaign market. And a colonoscopy, the exact same type of colonoscopy with the same quality rating from Health Grades between providers, ranged anywhere from $800 for the total cost to $3,500. So there is a wide discrepancy. It can vary from 300 to 500% within the healthcare industry for the cost of care. And a lot of times, that's very eye-opening for a member to realize what the cost of care is. And as we, have progressed towards more higher co-insurances and high deductible plans, the employee is paying a percentage of that. So it's important that they have the tools and the information to be able to make an educated decision about where they're going to go and have their routine or their care that is, arranged. Obviously, emergency care is a different situation. So, as I mentioned, it's a tool called Healthcare Blue Book. that our network is rolling out later this year. But it's a question to ask when you're looking at your network or working with a TPA. What transparency tools are available so that a member can have the information to make an educated decision? I also wanted to mention, and I found this interesting as well, is that higher price in the healthcare industry does not equate to higher quality. Very unusual. So quality is a very key component in our tool as well, in measuring, the results and the outcomes, in addition to what the cost is, because it is, both need to go into that equation for you to be able to make a decision. When looking at a network, usually the conversation starts off with what are the network's discounts. At HealthLink, we like to shift that conversation over to what's the cost of care, because a discount is only a discount off of what? If you're getting a 50% discount off that $800 colonoscopy versus that $3,500 colonoscopy, it's irrelevant what the discount is. So we really use kind of our best practices and our leverage by being a company owned by Anthem to go in and do a lot of fixed pricing when it comes to our provider contracting, being diligent in that area and reviewing contracts specifically for employers upon request to make sure that their dollar is going farther within their community. Some other member extras that are available from a lot of networks that you want to also consider when you're looking at your network or your TPA are all of the member extras that you typically would receive from a fully insured carrier. So your wellness tools, your online medical encyclopedia, preventative health guidelines, all those tools that are available when you're in a fully insured solution from one of those big fully insured carriers are available when you are in a self-funded solution. Really, to the employee or the member, the funding mechanism of their health insurance really is transparent to them. So they can be transitioned over to a self-funded solution really with very disruption in the services that they have, that they're accustomed to receiving. From a benefit perspective, as well as all these other extras, any disease management programs that they may be engaged in, all of those are available in the self-funded industry as well. I'm going to skip through that one for just a sec. Oh, got lots of transitions there. So moving on to the last component, which was reinsurance. This is where we have a little bit more complexity. People like Dave Fox are experts in this area, and there's a lot of different approaches and strategies and ideas on how best to put together your reinsurance package. So just kind of big picture, you're going to, in a self-funded solution, have two buckets of funds. One bucket is going to be your fixed costs that you pay every month, and then the other bucket is going to be where all the claims are going to be paid out of that your employees incur. In your fixed cost bucket, what's going to come out of that bucket are, one, the fees that you'll pay to your third-party administrator. Typically, they range anywhere from $16 to $25 per employee per month. So that's what you're paying, all of those services that we talked about that a third-party administrator provides. You're going to pay that. You're going to pay your network access fee. So you're going to pay that to a network because they've negotiated better deals with doctors and hospitals on your behalf for your employees to access. Typically, that's a HealthLink access fee is $8 per employee per month. And then the third fixed cost is your reinsurance. And there are two types of reinsurance. And what reinsurance does is it protects your bucket that you're going to pull all the money out for your claims. As I mentioned, in a self-funded solution, it's not unlimited. You're not going to, an employee has a $1 million claim. You purchase reinsurance to protect yourself from having to, be on the hook for that $1 million. So you purchase reinsurance, and it's broken down into two different types of reinsurance. You have reinsurance that's called your specific, and that's going to help you protect you from a single large claim. So as it says, you can think of this as a deductible on each insured that the employer has on the plan. It limits the total dollars that an employer would have to pay out of his claims fund for any one person. So an example would be you have a spec deductible, they call it a spec specific, of $10,000, and the employee has a $1 million claim. The employer will pay only the $10,000 spec deductible, and the reinsurance will pay the other $990,000. That's kind of an extreme example, and usually spec deductibles are a little bit higher. But that gives you an idea when you're taking a look at a reinsurance quote, which again, you'll have your broker or your TPA there to kind of walk you through it, of what that covers. Then the second type is your aggregate reinsurance. And this is a cap on the total dollars that an employer is exposed to for his whole group. So if an employer has a lot of small claims, so say the plague came to town and everybody got it and they all went in and they had to have a day or two at the hospital and get drugs, and the claims add up to $1 million. Then the aggregate attachment point in this example is $100,000. Then the employer would pay $100,000 and then the reinsurance would pay the remaining $900,000. So that kind of gives you kind of a safety net on that second bucket of claims dollars or your unfixed costs in a self-funded solution. And then, as Bill mentioned, there's a lot of alternative self-funding solutions out there now that are becoming available for smaller employer groups, all the way down to 7. Go back to that slide. There we go. Actually, in the marketplace, where you could go into a self-funded solution and have as little as 7 enrolled employees. And there are a lot of other protections and that are added into that reinsurance equation to help even protect it and make it more of a safety net for that smaller employer group, because obviously they're not going to be able to have as much fluid with their funds as a larger employer group would. So as I mentioned, who's eligible for self-funding? You really, if you believe your population is healthy and willing to fill out those individual applications, it's definitely an option to take a look at and see if it would be viable and more of a cost-effective solution for you. And then as well, employers that are looking to gain knowledge of their plan and use that data to make decisions about the benefits that they're offering to their employees. Really, you hear a cry. I just listened to a panel of employers last week, and they said, we just want the data. We just want to know what the information is. And then I also challenged them and said, you also want to find a quality TPA or broker that then can help consult you and help you understand what the reporting is. Because you can have the data, but it's what you do with the data that is important.
Abbe, would you say there's an average specific amount, $50,000, $60,000, $70,000?
Yeah, I see a lot of, and that's where there's a lot of, different ways you can approach that. Kind of an art to how you put that together to meet the price point of what the employer can afford. Another factor that's a good segue, I would say 50, 70,000. Bill, do you have any?
It really kind of varies on size.
Varies on, yeah.
And the predictability of the group increases with the more employees that you have. And so typically, I think in this area,
You would have to.
okay.
Illinois does have a minimum.
Right. And then okay. So from 10,000 up, typically, we'll see in between the $75,000 and $150,000 range, depending on where you might be. The other part that we might want to mention at this point is in selecting these situations, there's also the capability of putting in a captive to modify that to some degree. And so, Dave's here if we have questions about the captive piece as well.
Yeah, and I was just going to segue into, there's one other factor that you will see in a quote that goes into the equation for determining your stop loss or your reinsurance premium, and that is your contract type. So I don't know if you're familiar with this or seen this, but I thought I would show you in the 1215, 1218, and what that represents. That first number, which is the 12, represents the number of months that the coverage is in effect and that eligible claims incurred during that time frame are eligible to be paid. So we'll use the example of January 1st to December 31st for being our 12-month time period. And then the second month, and this is where there's a lot of complexity and creative solutions and meeting the price point of the client that can be adjusted, is that second number represents the number of months that a claim incurred during the 12 months of the contract will be processed and paid. So for example, a baby is born on the last day of the contract, which in this example would be December 31st. When you have a baby on December 31st, you don't walk out with the bill. There's a lag in the billing that you receive from the hospital and the doctors, typically 2 weeks, a month and a half. So on a 12-18 contract, that claim has until June 30th to be received and processed by the third-party administrator. So the higher the number, kind of the less risk that you're going to be on the hook for a claim that's not going to be covered by the reinsurance carrier, thus the lower the reinsurance premium becomes. The longer the number is, the greater protection for the employer. So just wrapping up here, some keys to look at when you're considering a self-funded solution. You know, a trusted advisor for sure, I highly recommend. But just like you would in a fully insured arrangement, you want to look at the plan design, including the total out-of-pocket, the network access, and then obviously the rates, the reinsurance. But some additional items that that we've kind of talked through today are how does the third-party administrator manage chronic conditions? Because chronic conditions, an example of an uncontrolled diabetic can cost on average $8,000 more than a controlled diabetic in a calendar year. So it's very important that there are some truly effective chronic disease management programs that are in place to contain those costs so that those chronic diseases don't become catastrophic claims down the road. Are there any other special programs that are being included? I kind of skipped over this, but a special program that HealthLink just rolled out that's a cost containment program is called telemedicine. And this is becoming a popular type of program to roll out to employees. It's a 1-800 number that an employee has access to call into, and they can receive a telephonic appointment with an actual physician that's licensed for the state that they're calling from. The physician will consult with them based upon whatever their condition is. Depending on what the condition is, they can actually prescribe medication to an in-network pharmacy as well as prescribe lab work to an in-network provider. They have the information of what the network is for that particular employee. And not only does it save time, for sure, that would be a great, huge savings rather than either calling and scheduling an appointment and going and waiting for a physician, or two, going to an urgent care. With this, you save the time, it's handled over the phone, but then two, the cost is dramatically less than if you were to have an office visit. The actual claim for a telephonic visit is $65. That's what's billed to the employer. They can decide if they want to assess a copay to the employee or not. Where an average office visit with a doctor is $95. So you got a $30 savings there. Or if the employee went to the urgent care or the ER, the average ER visit's around $800. There's definitely a significant savings, as well as just, overall employee engagement, and, we've gotten some very good feedback on that program. So you want to ask what other special programs are available and what's included. What do you have to pay for? Or is it included for free? That's another thing that you definitely want to make sure you understand and ask questions about. What type of reporting will you get? I know from the network, as well as many third-party administrators, they'll give you a sample of the reporting that you receive or give you a demo of the online tool that you can use, where you can actually pull the reports yourself if you choose to do so. We just talked about, run out is that second number of that contract type. You definitely want to know what those terms are and understand that and how that works from a funding mechanism. And then last, what type of technology and service model is available? Are there transparency tools that are going to be available to your members, to go out and see what the cost of procedures are going to be? Are there predictive modeling tools to help you build a 3-year strategy from a cost containment solution and your self-funded arrangement with your TPA? Just some additional items that you definitely want to consider when you're taking a look at, a self-funded solution. And that's kind of my basics of self-funding. Any questions I can answer?
As you can see, there are a lot more moving parts when putting together a self-funding process. And so some of the things that you've done, if you were coming from the fully insured world, that you've allowed or relied on the insurance company to do, basically are now at your control. And so doing the things that you need to do to modify the plan to better fit your employees and their environment, to engage in, for example, a wellness program that has a direct effect on the cost of your health care scenario. Right now, if you engage in a wellness program and you're fully insured, you're benefiting the insurance company, who has some restrictions to share back premium dollars that exceed or don't exceed the claim amount that they're allowed. small groups 80% or large groups 85%, but it's a big 80% because it's all their groups, not just yours. And so those loss ratios basically apply to the insurance company as a whole, as opposed to your individual group. Here, you can be in a situation where you're going to benefit for putting in the effort and the programs to help with the wellness and the claim effectiveness that your employees utilize on the healthcare side. The other thing is, in a small group world, the concern has always been, yeah, self-funding looks good, and I've got some young employees now, and they're really healthy, and they've aged out of maybe maternity, which we all kind of have an idea that, at some age we're going to have some children. And so I think this would be a great time to try it. But what in the future? What if it goes bad? What if it goes really bad? Well, in the old world, that was a problem because everything was health qualified. You went into a rating structure based on the health of the situation. In the small group world today, you've got the safety net going back into the community-based rate. We can just take a step back and say, okay, this isn't working. I'm going to fall back into a community-based rate. I'm going to wait for it to settle down and maybe take a look at doing something else. So you already know what the worst case scenario is going to be. And so it can only be better. So this is a good time to take a look at something. Again, knowing that you will have the tools available to you to evaluate your program and how you need to structure your program to best benefit your employee population. So it's a good time to take that consideration. It can be pretty simple too. And Abbe can jump in here, but in general, you can get into the ballpark of what your costs are going to be by sharing the plan design and your last two renewals on your group plan. You don't have to go out and take all those health applications, which typically kind of frustrates employees. They don't want to share some things. So, but you can go back and you can take a look at your last two renewals and your census and your plan design and come pretty darn close to a number on what the cost of the self-funded plan is going to be. So that kind of information can make life pretty simple. Other questions? If not,
I got one. Abbe, you were talking about all those numbers, 12, 12, 12. I think it might be important for you to talk about the renewal aspect of it too. In other words, the bigger number first.
So Dave, I would kind of show you the example if you were looking to transition from fully insured over self-funded. So Dave was referencing when you renew, there is a different strategy that you want to put in place with those contract types of where rather than having what you would call run out, where the claims roll over or go beyond the 12-month contract period, you would have run in. So I don't know from a pricing.
Well, I mean, I just think that it's important to note that you don't necessarily have to buy that long protection that sometimes gets expensive because your renewal is probably going to be like a 24/12. Mm-hmm. So even if they incurred it in the prior year, it's still going to apply in the renewal year. And those are typically a lot less expensive mm-hmm. because what the mm-hmm. What's out there. And so you can really price them right to it rather than the old invisible price. So
yeah.
The point is you don't necessarily have to spend a lot of money and focus on the run out because your renewal is going to cover that to whatever extent you want. Just another protection.
Okay. Other questions? It is quite an evaluation, and the questions always come when we start to look at it. So one of the first questions is what the cost is going to be. So it's a pretty simple way to get you to the ballpark. The next questions will come as you further consider that renewal piece. So with that, we've got another 15-minute break before we go into the large.